Good morning. Welcome back. I'm Ju Sun from Computer Science and Engineering. I'm an AI researcher. It's a great honor to host our great speaker today. The first speaker I want to introduce is Dr. Paige Nong. Paige is currently an assistant professor in in the Division of Health Policy and Management in School of Public Health, UMN. She got a PhD degree from University of Michigan, and the central theme of her research is trying to combine sociology, health informatics, and policy, try to enable trustworthy and effective health delivery. Without further ado, Paige, please. Let's welcome.
Great, thank you very much for being here. I'm happy to share my work with you today and kind of return us to the healthcare delivery side of the AI conversation. I think to set the stage, we hear a lot about how AI is transformative and revolutionary and going to solve all of our intractable human problems. I think we're all very familiar at this point with the image of the cyber brain and the human finger touching the robot finger, and sparks are flying. And I think that we're all pretty deeply steeped in some AI excitement and some hype. There are lots of promises when it comes to healthcare, right? And I think we've kind of debated and touched on those over the last couple of days together. Lots of hope for identifying efficiencies in healthcare, which is a relatively inefficient system, I think we can all agree, in the United States. Promises to improve health outcomes for patients, and increasingly with the ambient documentation tools that we talked about together, reducing clinician burnout, right? These are sticky, messy problems that characterize our healthcare delivery system. And it's really nice to hear there's a simple solution and all you have to do is flip this switch, or all you have to do is deploy this particular tool and it will solve this problem that's been taking some of our greatest minds years and years and we still have not solved. The question that I often return to in my work is, but what does this look like in practice? Right? I was reading journal article after journal article saying AI stands to transform the healthcare system, but I didn't see a citation attached to it, and I didn't see empirical evidence of this. My job, as I see it, is to try to kind of dig through the hype and sort through all of these claims about transformation and revolution and identify what is actually happening in our healthcare delivery system, on the health system side, and also for patients. So my work kind of falls into these two buckets. One is to understand how health systems are making decisions about the AI tools that they use or don't use, when they use them, when they don't use them, and if they design them themselves, how they design those tools. And then on the patient side, to understand how patients perceive and understand these tools to be affecting their experience of the care delivery system, both clinically and administratively. To start on the health system and hospital side, a few years ago, I did some interviews with academic medical centers that are kind of your prototypical early adopters. These big systems with data science teams and lots of resources who are kind of leading AI adoption in healthcare. I wanted to understand, this was in 2022, what are you using, how are you using it, and how are you making decisions about what you use? At that point, even among these very well-resourced academic medical centers, there was considerable variation in how they were standing up AI governance. Some of them fell into this top category, these really well-defined governance structures. Some of them have published their entire governance process, right? From intake form, problem identification, local evaluation, post-implementation monitoring. Some of them have really robust approaches to this question. But that wasn't the majority of the academic medical centers that I spoke with. Most of them fell into this middle category that we called emerging strategies. They were essentially taking existing clinical decision support infrastructure and governance approaches and kind of tacking on AI, right? Like, oh, you guys do some health IT stuff, you should also add AI to your portfolio and we'll kind of figure it out as we go. And then some AI governance approaches in academic medical centers relied almost entirely on interpersonal relationships and individual decision makers. So a chief medical information officer was essentially tasked with deciding, yeah, we'll turn on this tool from Epic, or no, we won't, or we'll use it under these conditions. And again, this is among large, well-resourced academic medical centers. So one of the kind of key takeaways for me and my colleagues was if we see this kind of variation among well-resourced academic medical centers that are early adopters, what does this actually look like across the country, where there's considerably more variation and diversity in terms of resources, in terms of technical capacity, and internal expertise? So we analyzed national data from the American Hospital Association. They do an annual survey of America's hospitals. This, in 2023, was the first year that we were able to include questions about AI use on that survey. So this was kind of our first opportunity to get that national look at what does this actually look like in practice in US hospitals. So we asked a few kind of key fundamental questions that we thought were really important to answer and contribute to the literature and our empirical understanding of AI in healthcare. Who is using the tools? The answer is it's about 65% of US hospitals that are using some kind of predictive AI or machine learning tools based on their responses to this survey. Hospitals that are system members, that are part of larger systems and have higher operating margins, are more likely to deploy these tools than their counterparts. Rural hospitals, critical access hospitals, and hospitals in areas with a high social deprivation index are less likely to be using predictive AI. This is not shocking, right? The ability to deploy these tools relies on resources, and so we see that kind of AI digital divide playing out in predictive AI deployment in US hospitals. The second question we wanted to answer was, how are they using them? AI is a really broad umbrella term that I think we've kind of wrestled with and discussed over the last couple of days. It can mean a lot of different things, from a logistic regression all the way to a large language model, right? People use this term to refer to many, many different applications. So not only are we talking about diverse tools methodologically, but in healthcare, we're also talking about diverse applications. We've touched on some of these together. We talked about the ambient scribe. We've talked about image processing. But really, these tools can be applied across the care continuum, from scheduling a patient, which we've discussed, through diagnosing and treating, all the way through the billing process, right? So when we talk about AI in healthcare, we can be referring to a large language model automatically responding to patient messages, or we could be talking about a predictive model that's predicting if a patient is likely to pay their medical bill, and then using that propensity score to refer them to collections agencies faster, right? There's real variation here, and so we wanted to get an empirical understanding of where are we falling here right now. The most common use of predictive AI in US hospitals is to predict health trajectories for inpatients. So this is something like the sepsis predictive model that lots of us are very familiar with, or trying to predict fall risk for inpatients, right? Most of the hospitals using these tools say they're using it for those purposes. Then the second most common application is to identify high-risk outpatients for follow-up care. This is something like a 30-day readmission prediction. And then the third most common application is to facilitate scheduling. So when we think about, the promises of precision medicine and the right treatment to the right patient at the right time, that's not exactly what's happening here in practice. We're doing a lot of sort of traditional risk prediction, and we're doing some administrative tasks in healthcare among most of these hospitals. The third question we asked was, what is the state of local evaluation? We know from the literature and from lots of different examples that when you design a tool in one place and you attempt to plug it in another place, it often doesn't perform well. We've seen this with the Epic's predictive model for no-shows. We've seen it with the sepsis model. Trying to do this kind of plug-and-play approach in healthcare often doesn't work because patient populations look very different from each other. The data infrastructures and approaches of these different healthcare delivery organizations also look really different. So the tools often just don't perform as well after they've been moved from one place to another. So we wanted to know, when they deploy these tools, are hospitals conducting an accuracy evaluation and a bias evaluation using local data? The answer is not as often as we would like. So 44% of the hospitals that say, yes, we're using predictive tools, actually conduct this accuracy and bias evaluation. Of course, I want to note, and we can, for any of those who are interested in survey methodologies or those kinds of details, we suspect this is a high estimate because of social desirability bias. People know that evaluation is important, and so we think that they're more likely to report that they do it potentially more often than they actually do. So this is a high estimate, right? I would treat this as a high estimate in your interpretation. 44% of hospitals using these tools are doing local evaluation for accuracy and bias. We wanted to look at, are there systematic differences in the types of hospitals that are implementing and then evaluating the tools that they use? And again, we see this kind of AI digital divide. The hospitals that have more resources, that are system members, and are in that top quintile of operating margins are significantly more likely to not only use the tools, but also evaluate them. So we're building on this unequal foundation. And to anybody who sort of studies healthcare or has deep experience in the healthcare delivery system, this is, again, not a surprise. When I work with my colleagues who are in safety net organizations, there's a federally qualified health center here in Minneapolis that I work closely with. We've been having these conversations since I came to Minnesota 2 years ago about what their experience is of AI, right? Some of these promises about reducing documentation burden for clinicians, for example, are particularly relevant to safety net organizations. Their clinicians and their other providers are at particularly high risk of burnout, and they're operating under real resource constraints. So when they hear promises of cost savings and efficiencies and preventing burnout, these are really appealing claims to them. They're operating under resource constraints that their academic medical center counterparts are not. But they are in a really difficult position because they don't have the data science team that Mayo Clinic or Michigan Medicine has to kind of pull apart a sepsis model and see if it works for their patients, for example. They just don't have that internal capacity. So they're kind of faced with two bad choices. One is deploy the tool, even though you can't be sure of safety or risk or validation. The other is don't deploy the tool and miss out on the potential value, right? If there is a tool that can actually produce efficiencies or cost savings or protect your clinicians from burnout, you're sort of missing out on that potential value. So they're kind of stuck in this challenging position where they can't vet the claims of these vendors who come and tell them, if you deploy our tool, you'll save $6 million a year and you'll prevent loss of all of these clinicians. They're not able to independently vet those claims, but could potentially really benefit even more than their academic medical center counterparts from a tool that could actually deliver on those promises. So there's a lot of work to do here in trying to support the safety net in particular as they try to vet these claims of AI revolution and transformation and actually protect their patients. So the takeaways for the health system and hospital side are that we're building on this uneven resource foundation. And it's something I think that we need to really be aware of when we talk about how AI is transforming the landscape of healthcare. That transformation is uneven and particularly bumpy for many patients and health systems in the US. There's a real need for technical capacity expansion. For those of us who are policy-minded, there are some examples from our relatively recent history of infusing resources for digital transformation in the US healthcare system. And for the folks who are policy interested, we can certainly talk about that. But we do have some muscle memory for how to do this, for how to level the playing field a little bit to try to make that foundation slightly less shaky and slightly less uneven. The vendors here play a really important role. What we found in that AHA survey was that 80%, 79% of the hospitals that are using predictive AI get it from their electronic health record vendor. Those relationships, because of the sort of smoothed pathway for data flow and implementation, mean that hospitals are often relying on their electronic health record vendors for these tools. And when we think again about policy implications and where intervention could potentially be valuable, I think that vendor relationship is potentially a fruitful place for conversation. Care delivery organizations, whether I'm talking to a critical access hospital or an academic medical center in an urban area, have routinely expressed the desire for guidelines and guardrails. We all know that if we're talking about a diagnostic AI tool, to turn to FDA. But when we're talking about that tool to predict missed appointments, or we're talking about a tool to predict 30-day readmissions, or we're talking about that tool that can be used to identify patients who are unlikely to pay their bills and refer them to collections faster, those tools explicitly don't belong to FDA, right? They're not clinical, they're not diagnostic. And so these hospitals and health systems are sitting here saying, okay, we've got all these applications, all these claims from vendors about how these tools are gonna save us millions of dollars and save our clinicians. But who regulates this? Who do we look to know if this is safe or if it's effective? There's a real gap there. And again, for the folks who are policy interested, we can have more of a conversation about that in our Q&A session. But this is sort of the high-level takeaways on the health system and hospital side. Now we're going to turn to patients. Patients are often a perspective that's missing when we talk about the applications of AI in healthcare. I think at the end of the day, maybe on Tuesday, somebody brought it up, but it's certainly not core to conversations about AI policy, to health system governance. Most of the academic medical centers that I interviewed for that project in 2022 had no patient representation in their AI governance processes at all. I'm currently doing a follow-up study with them, and most of the ones I've talked to now still, they're kind of debating it, they're thinking about it, they might do it in the future, but there's no substantive patient representation in their AI governance processes internally. So my work in this domain is really focused on understanding how patients perceive these tools, what they want and expect from their healthcare systems, and the implications for patient trust. So we asked, are health systems trustworthy AI users? This was a national survey of the US adult public, and the answer is no. The darker orange on the left indicates disagreement with the statement, I trust the healthcare system to make sure an AI tool will not harm me. We're at about 58% of people who don't think that the health system will protect them from AI harm. And similarly, for use AI responsibly, most US adults don't expect that the healthcare system will use AI responsibly. However, there is some good news. Patients really want notification. We asked if people wanted to be notified when AI was used in their healthcare, and I have never seen an agreement this high in any of the public surveys we've been doing for the last 10 years when it comes to IT use in healthcare delivery. We've surveyed people about data sharing, precision medicine, predictive models, all kinds of things. I've never seen agreement like this in one of our surveys. So for the health systems that are trying to kind of think about patient engagement, think about patient trust and perspectives, notification is really low-hanging fruit. We talked a little bit about sort of LLMs for generating responses to patient messages and ambient documentation. There are some health systems that have explicit policies that they will notify their patients whenever AI is used in patient-facing communication. From a trust and trustworthiness perspective, I think that's hugely important. Patients want to be notified, and they expect that they will be. And I think in order to bridge that gap in how patients perceive the health system as an untrustworthy AI user, notification is a high value step to take in trying to earn patient trust. So some key takeaways here. AI governance really varies, not only among academic medical centers who have large data science teams and the resources to build robust governance infrastructures, but across the entire US healthcare delivery landscape. Hospitals are using predictive AI actively, but not always evaluating it. I think back to that number, 44% say that they're actually evaluating the tools they use for accuracy and bias. We want to see that number go up over time. There's an organizational digital divide when it comes to AI, and resources here matter. I think we have heard, anybody who's been to any kind of panel or conference about AI in healthcare over the last 5 years has heard about innovation and disruption. But I think mostly what we're seeing at this point is lots of vendors kind of putting an interface on top of an existing foundation model. And to me, that's not terribly innovative or disruptive. I think that innovation and disruption will come from actually meeting patient needs, responding to patient preferences and desires about what the healthcare system can look like, and sort of instead of replicating the existing patterns we have of like revenue cycle management and trying to bill more, I don't necessarily see that as terribly innovative. Tools that can respond to patient concerns and priorities, their desires for the healthcare system, and kind of leveling that AI digital divide, leveling that playing field, I see those kinds of applications as more innovative and responsive to what our healthcare delivery system actually looks like. And then on the patient side, patients generally have pretty low expectations when it comes to the healthcare system's trustworthiness. There's a lot of work to do to close that gap. And I'm interested to hear in your thoughts about how we might do that successfully. But essentially what we don't want to see is like building up this image of a precision medicine, sort of digitally transformed healthcare system where every patient gets the right treatment at the right time and early intervention, and we're doing evidence-based medicine. We don't want to inflate that expectation and then have the patient experience actually look deeply unequal. We don't want to promise precision medicine for oncology, for example, through AI, and then the patient's actual experience of AI is kind of a clunky call center agent where they can't get through to somebody and they just want to like schedule their kids for an appointment at the same time so they don't have to come to the office at 2 different times in a day. We certainly don't want to be promising precision medicine, and then all we deliver is upcoding through an ambient scribe tool or referring them to collections agencies faster when they don't pay their medical bills. This like expectation experience gap in the literature we know is particularly problematic for trust. Trust in providers and in the healthcare system has been declining over the last 5 to 10 years. And my concern is that this kind of gap between expectation and experience could further undermine patient trust, both in their systems and in their providers. And I'm happy to take questions now. Thank you so much.
All right, questions? Yes.
So in your work, you focus on these large centers and systems. What I'm curious about is, or rather, are these smaller privately owned practices, which potentially could be much more agile, just less committees. And I'm just curious, is that something that you guys have looked into? Is that do you find any differences between what you presented out here with the academic centers and large healthcare system versus smaller private practices?
Do you mean for primary care?
Or including specialties as well.
Sure. We haven't looked. I don't think there are a ton of those left, to be honest with you. So it's not a large part of the market. And it is possible that they could move faster. That's certainly possible. I think with ambient scribes in particular, the 2024 version of this survey that we're analyzing now asked about ambient scribes, and those have taken off sort of across the healthcare delivery system, whether we're talking about sort of smaller hospitals, private hospitals, safety net hospitals. Sort of uptake has increased pretty considerably. So it's possible to move fast, right? We've seen it with the ambient scribe tools. Whether that's well advised and whether it sort of improves patient outcomes, we don't know yet because we don't have the kind of robust empirical evidence we need to make those claims. But it is possible that a smaller private organization could move faster. Yeah. Mm-hmm.
Other questions? Yes.
You mentioned briefly this sort of missing regulation hole for a lot of AI models that don't quite fall under the FDA. Do you have with patient expectations being so low in terms of AI in their healthcare, do you have like a suggestion for hospitals where in vetting these vendors? Because it's kind of up to them without the regulation in place to be making the best decisions for their patients because the government isn't doing it for them, or it doesn't even have any suggestions for them. So like what are hospitals supposed to do, or do you have a suggestion on, what they can do, especially with, this possible 10-year state regulation ban going into place in the next couple of weeks?
Well, I'm hopeful that ban will not survive because there is some really interesting work happening regulation-wise at the state level. So I'm hopeful that will not survive the reconciliation process. When it comes to the regulatory landscape. Like I mentioned, those diagnostic and clinical tools, they have a clear path to FDA, but the other things kind of don't. There are many potential regulators, right? FTC could certainly have a role. ASTP, we heard from Steve Posnack on, I think it might have been Tuesday. They certainly have a role, especially when it comes to vendors. And I actually think that ASTP has done one of the best jobs of these like potential regulators in the ecosystem. They put out a rule, HTI 1, I want to say a year and a half or 2 years ago, that should be in effect now, which includes all these different informational elements that a vendor has to supply to their customer as a certified health IT vendor. It's really helpful for transparency because hospitals, as they're vetting a tool, they need to know what kind of data was used to create the tool, how has it been tested and evaluated, where is it used, who's accountable, we need information about what these tools are and how they should and shouldn't be used. And those informational elements from ASTP, I think, are a really great move forward. That is a little bit bounded because it's about the relationship between the EHR vendor and their customer, which is impactful, like I mentioned, but certainly doesn't cover the entire landscape of AI tools. Although they do explicitly include those administrative tools under that umbrella for HTI-1. So a vendor should be supplying all of those informational elements, whether we're talking about a billing tool or if we're talking about a diagnostic tool, which I think is great. I mentioned FTC. The Office of Civil Rights under HHS also has a role to play when we think about bias and discrimination through these tools. But I was talking with Katie, who was one of the presenters yesterday from the Bipartisan Policy Center, and it's sort of like because there are so many potential regulators for those administrative tools, nobody's a clear owner. And so it's just sort of falling into this gap right now. So I've seen hospitals take lots of different approaches. Some say, we don't care what it is. We are going to sort of follow our AI governance process for any AI tool. We don't care if you're applying it to billing or if it's, a diabetic retinopathy tool. It's all going to go through the same kind of robust evaluation. I think that's relatively rare. I think in lots of places, based on these qualitative interviews, the administrative tools are seen as low risk. They're often marketed as low risk because you don't have the same kind of like medical liability concerns. You don't have the same sort of misdiagnosis or mistreatment concerns as you do with diagnostic and clinical tools. So there is sort of a perception that's sometimes unspoken and sometimes spoken very loudly that administrative tools are low risk because we don't have medical liability concerns. So go ahead and turn it on and see how it works. Right? I think that's more common than the former version where there's a robust evaluation regardless of application. So what hospitals should do, I think, is leverage HTI-1, leverage those informational elements, make sure they're getting good information from their vendors and running it through an evaluation process internally. I think that's sort of the ideal approach while we wait for better kind of clarity on regulation.
Thank you for sharing your research. So are you, in your research, are you seeing any evidence of improvements in continuity of care, especially outside of systems? And I don't know if AI's, is AI contributing to that, or are you seeing efforts within these systems to try to share knowledge between systems?
I think that there is a hope that AI could support sort of information sharing and interoperability, but for my mentors who have been working on interoperability for 20 years, it's one of those intractable problems, right? We've been trying to come up with ways to kind of get around the silos and fragmentation through HIEs, through all of these collaboratives and networks, through PecorNet. I mean, there have been all of these kinds of efforts to smooth information sharing. I think there are what I've heard so far is kind of high-level general hopes that AI can help. I haven't seen any kind of empirical evaluations of those kinds of tools, unfortunately, but there's lots of hope for it. Yeah.
Hi, great talk. So, I mean, some form of artificial intelligence or AI has been used in the healthcare system for years. So I was surprised to see sort of the increased sort of mistrust more recently. Are there approaches or methods that that you think is sort of driving this heightened mistrust in healthcare systems as it relates to AI?
It's a good question. I think in some ways it just reflects a general kind of decline in trust in the healthcare system generally over time. So it almost could be tool agnostic, and it's just, especially when it comes to administrative applications, folks don't have a lot of trust in their healthcare system to sort of, we call it in the trust literature, fidelity, to abide by the patient's best interest. I think in clinical care, patients often still have that confidence that their provider will be acting in their best interest. But on the administrative side, it's pretty clear from the research that people don't believe that. So when we ask about, I didn't include this in the slides, but I did a survey a couple of years ago trying to understand if patients make that clinical and administrative distinction the way that our policy framework does. And it was actually the inverse of our policy framework. So patients were more comfortable with clinical applications of predictive models than they were with the administrative ones. And we didn't even tell them about the potential consequences of these administrative applications. We asked about determining eligibility for kidney transplant, predicting colon cancer, predicting sepsis and stroke in an emergency. Those were our clinical examples. And then the administrative ones were predicting missed appointments and predicting payment of medical bills. We didn't say they'll refer you to collections or they'll double book your appointment. We didn't even include those downstream consequences, but discomfort with those administrative tools was much higher. And I think it reflects this underlying sort of distrust, experience of financial toxicity and harm in trying to get care. And I have a graduate student now who's doing some more work on the impact of AI tools and surprise billing. But I think that it's that underlying sort of understanding that the healthcare system is not necessarily serving personal interests outside of that kind of clinical and provider relationship when it comes to things like billing and administration. But qualitative work there would be great with patients if we have any qualitative researchers in the audience.
Quite enough insight, it seemed, because you don't have all the data. Are your next steps in research going this way? And by the way, as an aside, I'm a practicing family doc from Rochester, New York, and a professor in the department there, and I think all your comments were spot on for so many different things.
Oh, thank you so much.
Great job.
I think there is a ton of work to do here. This kind of slice that I presented today is survey-based, but I think there are all kinds of other ways that health services research and health policy research can try to get a better understanding of the ways that these tools are impacting care delivery and patient experience. For example, billing. My colleague Hannah Nieprash, who's also here in the Division of Health Policy and Management, we're working on analyzing claims data, trying to understand billing behavior. I think there are ways that the AMA does surveys of their clinicians, trying to understand what's the clinician experience of this. I think there's no lack of important research questions to ask, which can sometimes feel daunting, but is also encouraging because we have lots of opportunities for good work to do.
As a quick follow-up question, you mentioned that a lot of these administrative AI tools are considered low risk in the sense that they're low immediate bodily harm to their patients. But because these are being implemented more quickly, it sounds like, than the clinical versions, is there any concern of like data loss or like an increase in potential like privacy concerns and implementing all of this new technology really quickly without it going through the more rigorous process?
I think that on the kind of healthcare delivery organization side, especially because there's often a reliance on the electronic health record vendor, there's sort of a feeling that like we don't need to worry that much about it because we already have this existing relationship and the electronic health record vendor already has all of the patient's data, right? So I think that the perception is if we're an Epic customer and Epic has this tool available, it's easy for us to turn on. They already have all of our data. And so the concerns about privacy maybe aren't taken as seriously as when a hospital or care delivery organization vets a third party, like external vendor. The folks that I've been talking to over the last couple of weeks have actually recently stood up vendor evaluation processes. So if they're considering a tool that's not from Epic and they're an Epic customer, they actually sometimes contract with like a consulting firm to do an evaluation of that vendor, to kind of vet their cybersecurity and privacy practices, to evaluate their claims about the tool. Again, that's only an approach that's available to like a small kind of slice of the healthcare delivery system in the US for the folks that have the resources available to contract that out. But it is a new approach that I'm seeing, that for those kinds of relationships that they're potentially considering building that they don't already have, like they do with Epic, they're doing a vendor evaluation that's separate from like a specific tool evaluation. And so it's kind of like that trusted developer idea of like, we've vetted your privacy and cybersecurity approaches and how you tend to build your tools, and so then we can onboard you. But it's almost in a lot of ways like an outsourced process, which I found really interesting. I hadn't heard about it before I started these interviews. There's one here.
Here.
Yeah, thank you for this. I think this is some really insightful research. I'm curious on steps you see moving forward for bridging the already existing but now layering AI on top of it digital divide. I know in terms of like a vendor perspective, you're probably going after health systems that have the ability to invest in things, or even teams that are able to connect your data sources and stuff, especially if you're not the EHR already. I know in the machine learning community, kind of as a whole, there's some kind of tension and back and forth between open source and closed source communities. But in this scenario, right, we also have HIPAA, we have where is the data actually contained. Yeah, I would love to hear your thoughts.
Yeah. To the point about sort of vendor behavior and targeting these larger, wealthier systems, a really surprising finding from my qualitative work that I did not expect was that even these very small critical access hospitals in rural locations, federally qualified health centers that are operating under extreme resource constraints, they are getting incredibly aggressive vendor pitches. At one of the FQHCs that I work with, individual providers were getting cold emails from vendors about AI tools. So I was surprised because I expected them to kind of be going after, Mayo and Michigan and Stanford and Duke, but they are equally kind of targeting these really small organizations that are, like I mentioned, in that difficult position of trying to vet all of these claims and deal with just a real inundation. People are even getting cold calls at critical access hospitals. So there's a lot of pressure that they're experiencing. In terms of the technical capacity expansion piece, for those of us who've been studying health IT since the introduction of the electronic health record and the meaningful use and trying to get these things off the ground and used sort of properly and effectively, there are lots of echoes that feel very familiar when we're talking about AI and its potential and its revolutionary transformational power. I think what we've seen since the introduction of electronic health records is maybe something different from what was originally promised. Providers have been really kind of disappointed and burnt out from this tool in a lot of ways. So I'm a little bit concerned about that. But I think when we're trying to level the playing field and think about narrowing the AI digital divide, we do have examples from the Regional Extension Center model, for example, trying to help small, independent, under-resourced, and rural organizations stand up on an electronic health record by infusing financial resources and technical capacity expansion. It was highly effective. It really was. Now, I don't have a crystal ball, and I certainly would not pretend to be able to predict what will happen at the federal level with resource infusion into under-resourced organizations. But we do have kind of a model that I think people are trying to creatively adapt for how to roll out technical capacity expansion and support these organizations as they try to deal with all of these claims about AI's potential power in their organizations. So some interesting work, a handful of collaboratives and networks and organizations that are trying to kind of replicate that approach of technical capacity expansion.
Thank you.
Thanks.
All right, so for the sake of time, let me close by asking one more question to you. So a lot of people, especially computer scientists, are talking about artificial superintelligence. So if I look at medical care, there are a lot of superintelligence. For example, a lot of imaging machines, like X-ray or MRI, that's beyond our capability, right? We can't really see inside human bodies, but these machines can do that. So by that standard, I call them superintelligence, artificial superintelligence, okay? So historically, when people introduce these to healthcare system, did they actually consult all the stakeholders? I mean, who actually pressed the button and say, okay, we can start to use S3, we can start to use MI machines?
It's a good question, and it kind of speaks to the gap between creating a really cool technology that seems like it's going to solve all these problems and actual implementation. And in healthcare, it's a particularly challenging pathway to go from, oh, you've created something that seems like it really responds to this need, it's gonna solve this problem for us, and then in practice, like the best practice alerts that pop up for clinicians. And their goal is to just sort of get out of them as fast as they can to keep doing their work, right? The BPA sounds like a great idea, and then in practice, when humans are interacting with it, it's kind of a different story. And different care delivery organizations have different approaches. What I have heard, which is pretty encouraging, is that in these governance processes, the service line has to be consulted. So if this is a model that's going to affect a cardiologist's workflow, they bring in cardiology and they require sort of consensus from the cardiology department. Are you okay with this? Do you want it? Do you have an alternative? How do we think about this? Because precisely because of that problem of if you give something to somebody and tell them this is going to fix your clinical practice and it's going to transform your workflow and they didn't want it, it's a waste of time and resources. So I do see some good signs of actual consultation and engagement with the folks who are going to be using the tools on the clinical side, less on the administrative side.
Okay. Thank you very much, Paige.
Thank you.